Welcome, everyone, to our third and final day of the annual meeting. We are very delighted and honored, actually, to have increased participation every day in our meeting. So I'll give you a brief synopsis of what happened yesterday on day 2. So we introduced 2 new pieces of work yesterday from the APMEN Vivax working group. First, we had our linchpin, Dr. Calvin Lynch, introduce you to the prioritization framework, and she gave you a teaser of the type of questions, the type of priorities that we're trying to systematically capture from the NMPs, from the researchers, from the CSOs and other stakeholders, so that we know exactly what are needed for Vivax elimination in this region. And in the second piece, I introduced to you the options assessment toolkit, which will hopefully be ready by next year. And in between these 2 presentations, we heard from Veronica about her study, and where she found that it takes about 3 years to have anti-malaria policy change in this region. And she urged that further work is needed to ensure that this process is reduced, the timeline is reduced, so that the new tools can be introduced and implemented for the countries to reach the elimination target by 2030. And then we had 2 stalwarts present. Dr. Kamini Mendes gave us an account of patient adherence and shared her experience of elimination in Sri Lanka. And she reiterated that we need an integrated approach of vector control, early case detection and treatment. And then when the caseloads are lowered, then supervised treatment or directly observed treatment can be the way ahead for virus elimination. And finally, we had Dr. Chansura present on the early experiences of G6PD testing in the region. She gave us a reminder that the current tools are not ideal, but they do need quality training for them to be implemented accurately or effectively by health workers in the field settings. And unfortunately, we had some technical glitches and she could not attend to the Q&A session. And we assembled all the questions to her, and she was kind enough to respond to those questions. And we have collected them in a Word file, which I will be uploading onto the chat box right now. So if you can see the file up there, that's the response from Dr. Chansura to the questions asked in that session. And what I need to tell you is that our running competition on the mascot is still on. You have a limited time to upload your submissions, and we will be taking a look at how many likes or you get. The ones who get the most likes will have a surprise prize coming onto your post pretty soon. So I will look forward to your submissions today. I think we'll only have a couple of minutes. I think we have 30 minutes or so for you to submit. So having said that, I will now give it over to Sandy for proceedings for today. Thank you, Sandy.
Thank you, Dr. Manash, and welcome back everyone to day 3 of the APMEN Vivax Working Group annual meeting. Today we'll be focusing on access issues. So we'll be looking at targeting new tools to achieve impact and in reaching Vivax patients. We'll be discussing issues and strategies being used to access remote populations and engaging with other sectors. So without further ado, I would now like to introduce Mr. Leo Makita, who is the Program Manager for Malaria and Vector-Borne Diseases at the National Department of Health in Papua New Guinea. He's been working on malaria over the last 4 decades, and he is trained in entomology, parasitology, microbiology, and in public health. Over to you, Leo.
Hi, Sandy. Leo hasn't come online yet, so if you could continue, please.
Okay, so the talk, the next session is going to be on targeting new tools to achieve impact. And Ross Howells will be presenting the slides. So Dr. Ross is a malaria epidemiologist working at FIND and the Global Alliance for Diagnostics. Her area of expertise include G6PD deficiency, congenital hemolytic anemia, and hemolytic anemia. Over to you, Dr. Ross.
Thank you, Sandy, for the intro. And thanks for the opportunity to present on this work today. So what I'd like to talk about is to provide an introduction to diagnostic network optimization. So I'll illustrate what this is with a few examples, and then we'll look at how the approach could be applied to help plan the rollout of G6PD testing to accompany new Vivax radical cure regimens. Next slide, please. So, as I'm sure you'll agree, diagnostics are critical to healthcare systems. Accurate diagnosis ensures the right care for patients, informs surveillance, and plays a key role in global health security. In reality, however, diagnostics are often unavailable, inaccessible, and even when capacity is there, often heavily underused. So to achieve impact, testing must be accessible to the patients who need it. And figuring out where in the health system pyramid, and more specifically, where geographically within a region to position diagnostic capacity is a trade-off. So simplistically, the more testing sites you have, the better your coverage will be, but higher the cost. So currently, diagnostic network planning is often based on manual methods and expert consensus, which has definite advantages, but can lead to limited objectivity with respect to some of the trade-offs. So in recent, there's been a move towards a more analytics-based approach, namely diagnostic network optimization, or DNO. And this approach aligns demand for testing with local capacity to then improve access in the most cost-effective way. And DNO so far has mainly been applied to lab-based tests for TB and HIV. So we'll first look at a couple of analyses on TB to explain a bit of this further. Next slide, please. So a DNO analysis was performed for TB testing capacity across the Philippines. And the key questions addressed here were, firstly, how to improve usage of the existing gene expert testing network. And secondly, how to increase testing coverage. So the colored dots on the maps represent the location of gene expert devices, with different colors indicating the observed or the projected utilization rates. So that is at what capacity the device is being run at. So red indicates that it's being used at less than 25% capacity, while green is greater than 80%. So a well-managed network will aim to be as green as possible. And what you can see is that in the DNO analysis, this helped to identify the diagnostic gaps and then filled these either by improving the sample referral networks associated with each site, or by recommending the addition of new gene expert devices. And so under the projected future scenarios, you can see that both the density of points increases over time and the points are turning green. So by optimizing the testing network, more patient samples are projected to be tested and more patients are actually getting diagnosed. And the whole system is being run more efficiently, more greenly. Next slide, please. So similarly, this was seen in Kenya. So the map on the left shows the sample referral system at baseline in Western Kenya. What you can see, or maybe not see, but what this map represents is that some sites were running at overcapacity, but most were actually at undercapacity. And then on the first 2017 baseline map with the dots, you can see again that there's quite a high density of red dots. Also, they noticed that testing wasn't always being done at the closest lab to the health center where the patient was actually presenting. So the DNO scenario aimed to scale up testing coverage and increase demand by accessing missing cases. And again, you can see that under the optimized scenarios, so the 2021 map and 2023 maps, the red dots are turning green. So more samples are being tested in a more efficient way. And the DNO projections for both the Philippines and Kenya examples were then used in their current TB national strategic plans. Next slide, please. So these initial projects indicated that there was a need and a strong rationale for making these DNO analyses more widely available. So FIND partnered with Lamasoft to develop OptiDX, which is a bespoke DNO software that will be made freely available to Ministry of Health teams so that you can conduct your own analyses to address your own questions directly. And this work is all being funded by the Gates Foundation and USAID. OptiDX, the tool itself, is currently being piloted in a few countries and will be made available at the end of the year. And here in the image, you can see a screenshot of the online software interface where you input the required data sets and then you can manipulate the different outcomes and parameters. Next slide, please. So what's the relevance of all of this to Vivax and G6PD testing? Well, unlike malaria RDTs, in most situations, quantitative G6PD testing isn't going to be suited to being universally rolled out across all settings where Vivax patients might be diagnosed. So for example, as Dr. Chansuda mentioned yesterday in the Thai context, low Vivax case numbers leads to low demand for G6PD testing, and therefore you risk wasting tests if they're sitting in health facilities and unused before they expire. So what we need to do is work out the best way to maximize accessibility to Vivax patients within the local constraints. And so depending on your country preferences, this will likely involve different levels of the health system, with tests concentrated in higher burden areas, and probably in those higher burden areas being closer to the peripheral testing sites at the community level in those high burden areas. So countries will have different constraints on where the test can go and where primaquine or tafenoquine may be made available. And the framework, the DNO framework is highly flexible around these considerations. So for example, if you were interested in seeing how a mobile radical cure team on motorbikes might look, for example, you could implement that in a similar way to how the TB sample referral networks were done that we looked at earlier. Next slide, please. So as with all modeling, the DNO models are very data hungry, and information is needed on the location of the potential testing sites, so where you might introduce the G6PD quantitative test, and the distribution of demand, so where the patients are being diagnosed with Vivax. Costs need to be detailed, and specific constraints and assumptions need to be carefully thought through so as to make sure that the outcomes are relevant and useful. These are just a few examples. Next slide, please. So there are a number of different outputs that can then be derived, and the priority given to these different outputs metrics will be determined by you, the NMEPs using the tool. They include metrics of coverage, so how many patients would receive a G6PD test under a certain scenario. Also efficiency, so both in terms of cost effectiveness, how much does my overall network cost given the number of tests that it will allow me to use, and utilization. So back to those red or green dots, how much are my devices actually being used? Equity may also be prioritized. So certain areas may not be covered in the most cost-effective scenario, but may be important to include to ensure fair access to good case management across your population. So the DNO model allows you to define these different scenarios and then to compare the outputs between them and devise an optimal strategy. We anticipate that the results of this work could help you to understand the feasibility of introducing G6PD testing, to anticipate the broader system requirements in advance of policy changes bringing in new radical cure tools, and also to budget for your future procurement needs. Next slide, please. So the next steps, in the first instance, we're working with one Ministry of Health to pilot this system for the G6PD test. And then we hope to make, if this all goes well, we hope to then make this more broadly available so that NMEP partners can implement it directly with your own data. As I mentioned, the OptiDX system is very flexible, so it can be updated as we learn more from the implementation studies and the operational research that's been carried out that we've heard about this week. And so finally, please get in touch with me if you think this might be of interest to your program, or if you've got any suggestions, we'd be grateful to hear your thoughts. Final slide, please. So a lot of people have been involved in all of the OptiDX and the DNO work to date, involving people from ministries of health, academics, Lamasoft, the developer, and the DNO team at FIND. This work's all been funded by the Gates Foundation and USAID through PEPFAR. So thank you to all of those different players. I've copied a couple of articles at the bottom there with more information, and there's more information on the FIND website. And yeah, please do get in touch if you'd like to discuss this further. Thanks for your attention.
Thank you, Dr. Ross, and for your presentation, and makes us think about how we can target implementing G6PD analysis and also to achieve cost effectiveness. Now we'll have the session on lightning talks with 2 additional speakers so that we can learn more about access and multi-sectorial approaches. We're going to have exactly 5 minutes per speaker, and I'm to keep time on that. So we'll be watching the clock very closely for this session, and I will be giving a reminder. So the first speaker will be Dr. Isaac Quay. He is a professor at the Regent University College of Science and Technology, Ghana, and co-chair of the RBM ARMPC Multi-Sectorial Working Group. He's the founding chair for the Pan-African Vivax and Ovali Network, which is working in collaboration with NMCPs to refocus attention on the emergence of Vivax and Ovali in Africa. Over to you, Dr. Isaac.
Thank you, Sandy. I really appreciate the invitation to be part of this. So as has been said, I'll be looking at the integrated activities with the perspective of multi-sectorial working to detect and prevent malaria. So I think we all understand that the incidence of malaria disease is largely heterogeneous. The geospatial setting differs from one area to the other, and therefore it is important that we are able to identify where the parasite is and then be able to treat. And in most cases in Africa, we have case detection either passively or active passively. That is when patients present at the clinics with fever. And then when community health workers actually reach out to communities to find out those who have a sign of disease, and then look for the patients in that setting. And then in active surveys where we have the National Malaria Control Programs engaging in MIS or DHS-IS activity within a particular community to access data on the incidents. So what we normally do is to scale up the case detection, treatment and prevention as we go towards elimination phase in most of the countries, especially in Southern Africa where elimination is the goal. And as we do this, as we all know, Africa has largely focused on P. falciparum as the main agent, but we are aware now that P. Vivax is becoming a problem. And this is what the Pan-African Vivax and Ovale Society has been able to work on, drawing people's attention to the emergence of the parasite on the African continent. And I think I acknowledge Rosalind for a lot of work that she has done in this area. So the SDG and GTS goals clearly imply that every one of the 17 goals that are stated has some aspect of malaria that is in it. And so we want to say that to be able to achieve either the SDG or GTS goals, we have to ensure that malaria is eliminated. And that is key. And that's what we encourage everyone to advocate for. So we cannot do this, as we've been talking about in the past 2 days. We can't do this alone. All sectors within a country or within a community need to join together and participate in these activities, to collect data from all sources and especially looking at the high burden or areas that are hotspots for intervention. The next slide, please. So we suggest in multi-sectoral activities, these key focal areas. This is one, high-risk populations or communities, groups with risky professions like the military and the mining areas, those in farming communities that are remote, and especially also in rice cultivation. And we are aware that especially Japan is engaging Africa to increase the production of rice. And at the same time, they are looking at the possibility that they can assist the communities to mitigate any effect of increasing transmission of malaria, as we know, with the presence of floods and water bodies around. And then also we're looking at vulnerable populations, in particularly school children, pregnant women, in the slums and migratory populations. And then on key areas like nutritional interventions, towards anemia in Africa. Next slide, please. So we also suggest that the path that is recommended that anyone can take is number one, advocacy for multi-sectoral activities, and then implementation of the ARMPC guide that IBM has recently released. So in the advocacy in Africa, we have what we call the End Malaria Councils. And these have two or three key areas. Okay, they engage leadership and then look for finance and then look at ways to use tools that are available for the activities. Last slide, please. So we have the site for the guidelines, and we encourage each one of us to be able to access these guidelines. They give specific practical activities that each one of you can look at and move on with with looking at how to detect malaria multi-sectoral. Thank you very much. And I appreciate the invitation to be part of it.
Thank you, Dr. Isaac. You have 13 seconds to spare. And thank you for joining us. I know you're on your way to the airport or something, so thank you.
Yeah.
Next speaker is Mr. Lieven Vanave. Lieven is a program manager at Malaria Consortium Cambodia, and his scope of work includes the qualitative implementation of Malaria Consortium's program, in particular guiding the national teams in implementing the regional artemisinin initiative, resistance initiative of the Global Fund project in 6 northern provinces, international border areas, and contributing to the malaria elimination targets set out by the Cambodian government. Over to you, Lieven.
Thank you very much. Thank you very much for the introduction, and thank you very much for inviting Malaria Consortium to present our activities. As you said, indeed, Malaria Consortium is working along the most remote areas in Cambodia, in northern Cambodia, bordering with Thailand, Laos, and Vietnam. The goal of the project, the objective, is to make sure that malaria services are expanded and are reached, are available for people in these most remote areas, mobile people, migrant population, local people going to the forest up and down. Next slide, please. So how do we provide these mobile malaria services for these hard to reach communities? Well, we all know that in Cambodia, most of the cases, malaria cases, are situated in the forested areas with a lot of small family plantations. So what we try to do is work with the community, and that's why it's in red on the slide. It's really a job with and within community. So we train and we look for local mobile malaria workers, and these local mobile malaria workers are supported by MC staff, but they really try to increase the early detection and treatment. So they will not only test and screen febrile patients or people showing fever, but they will also test everybody at risk in their location. How we define this location depends on a lot of factors. It can be spatial factors, it can be the movements of the people. Yes, now you go a bit too slow, thanks. Okay, keep this slide, please. So there are 85 mobile malaria workers working in 6 provinces all along the border. Some of them work in malaria posts. These are posts open 7 days per week with 2 mobile malaria workers, and they are placed at exits, entries of the forest or forested areas, where they can test everybody who's passing by, giving also health education, bed net distribution if needed. Then we have a group of mobile malaria workers doing outreach activities, and they choose 8 days per month. They go to areas, sometimes with overnight stay, where they know that people are working in plantations in the forest. They're local, so they know very well what is happening. If they find the PF or mixed case, they also do the co-traveler investigation. So they will test all the people who were at the same time, same place of assumed infection. So these are the main activities. Next slide, please. So if we look at only the first 6 months of this year, these 85 MMWs based in the local communities, they did more than 28,000 RDT tests. You see the positivity rate is really low. PF mix is extremely low, and we see much more PV cases, of course. Malaria, Cambodia is in the elimination phase, so the focus goes more recently to Vivax, of course. And as you can see, our teams also find much more Vivax cases in those areas now. Next slide, please. So what are our key messages? Well, that working with local people who know the local context, the local culture, the local language, often they are really key, and they can also be key in the PV radical cure. They are really the driving forces among their peers, because they're also local people, so they can motivate them. They have a link, there's the proximity, they speak the same language, and they link with the health center. MMWs can also do the 3-7-14 follow-up, as done now. And we will also, but now we have to stop due to COVID, but in community dialogues, give this problem or give this challenge to the local communities. How will you increase the treatment? Challenges, yes, we know all the challenges of radical cure. They have to go far, they have to take the 14 days treatment, but we are really thinking, is there no possibility of mobile nurses going to the hotspots? Because in our areas, they're most, the PV is really, you can really find it in hotspots. So the mobile nurses, mobile T6PD nurse would be a good idea, or maybe why not train MMWs in those specific hotspots where they need a lot of this test T6PD test to perform the test with good support. We know that they can do it. Next slide, please. So I would like to acknowledge the Ministry of Health, of course, the national program CNM, UNOPS, the principal recipient for the Global Fund, and then the Malaria Mekong-Free platform, the CSO platform in the region. Thank you very much. There's one more slide to say thank you. Thanks. No sound.
Sorry. Thank you. We now move to our last speaker, Mr. Leo Makita, and also reintroduce him. I think we had technical difficulties before. Mr. Leo is the Program Manager for Malaria and Vector-Borne Diseases at the National Department of Health in Papua New Guinea. He's trained in entomology, parasitology, microbiology, and public health. Over to you, Leo. You have 5 minutes for your presentation.
Okay, thank you very much. Thank you for this opportunity. Sorry, I had technology problems, couldn't get in earlier. Next slide. What I'd like to talk about is a partnership that we've developed with Australia, China, and Papua New Guinea, where Australia does the funding. China provides support, and PNG is the beneficiary. So the project is founded on a partnership model, and the partners have made a commitment to uphold specific principles and values in delivering the project. We actually go by mutual respect for the contribution of each participant in this agreement. So the recognition and utilization, we try to maximize the advantage of each participant so that all participants are equally benefiting from this collaboration with other bilateral and multilateral development partners where, so it's an open partnership. The project is, sorry, next slide. The project has a three-tiered governance structure with representation from all 3 countries at each level. We have the very high-level strategy and direction that includes very high-level government officers from each of the partners. And then we also have the technical directors, which are actually deputies to the high-level partners. And then we have an administration that administers the project. This support is provided by a neutral project management unit, which is completely independent, and they liaise with all partners to be able to agree to what direction we move in. And the project has brought together relevant government departments, and in Papua New Guinea, I think this is the first time we've actually brought together different departments. That's health, national planning, foreign affairs, and it has actually worked out very, very well, and it's actually quite successful in implementing the partnership. Next slide. Well, our partners, as you can see, is the Department of Health, Foreign Affairs, National Department of Health, our Central Public Health Laboratory, Institute of Medical Research, our School of Medicine, and the provincial health authorities. In China, the partners include the Ministry of Commerce, the National Health Commission, and the National Institute of Parasitic Diseases. And in Australia, the partners include the Department of Foreign Affairs and Trade, Barnett Institute, and the Australian Defence Force Malaria and Infectious Disease Institute. So these are the kind of partners that we have that are working on this project to try and address some of the issues. And next slide, I think that's about all I have to say about this partnership. But okay, next slide. Oh, that's probably the end. Thanks a lot.
Thank you, Dr. Leo, for keeping time. We have 32 seconds to spare. I would now like to turn over the chair back to you, actually, for the Q&A session.
Okay, Sandy, thank you very much. Like I said, I do apologize for being late. It was a problem with connection issues. So, well, we've had a couple of speakers now. I think what we need to do now is to move on to some of the questions that have probably come through or not. Can we sort of look at what questions people did raise while the talks were going on? Sandy, you got some questions that were raised?
I think there's a question for.
It looks like there was one.
There's a question, shall we go in parallel? Let's see. Dr. Leo, for you, there's a question on how this type of high-level partnership can increase access to Vivax patients at community level, either directly or indirectly.
Well, I think this project directly is involved in the issues of Vivax, because we have our collaborators working on the issue of the G6PD testing, the short course Vivax treatment, 14 to 7 days. So we got a lot of other issues that our collaborators are actually working on to inform policy for the department. And that is the direct benefit of this partnership we have in terms of Vivax.
Okay, thank you. There's another question for Dr. Levin. How do the teams build trust with communities, and how long does it take?
Well, that's thanks for the question, Kemi. That's a good question. The fact that we really choose for community members, people selected by community, it doesn't take that long. I mean, it's very difficult to put a date on it, days, months, but I think the most important step is the introduction of the project as such, the introduction of staff supporting the mobile malaria worker. But even our staff, we choose sometimes or select staff because also based on their local knowledge. Some of our staff also belong to some ethnic minorities, so they speak the language. So for them, it's already a step further away. So a step not further away, step one, let's say, sorry, to get in contact with the communities and then to define together with the community, with the health center as well, who can be the mobile malaria worker. So it's really somebody from the local community, and that's the big advantage in most cases. So that trust is built up quite quickly, I would say, but I cannot say that it's exactly a few months or a few days. If that is an answer to the question from Kemi.
There's also a follow-up question from Kemi. So do migrant patterns shift regularly, and how do you plan for this?
Yes, thanks, Kemi. That's a very good question, and the biggest challenge in these activities. Planning is difficult, but what we have to do is monitor really well. So the teams are who support the mobile malaria workers, they are sitting together every month. We have a very strong monitoring system based on our data, of course, but at the same time, through the network in the communities, we really try to follow up very well what is happening. And again, our community people, our network, they are the most important source of information. And these movements of people, these professional movements, during their legal or illegal activities, are changing indeed very fast. It can change because of the season. It can change because of the increase of rangers trying to protect the forests. So you have these changes. So sometimes we keep the same mobile malaria worker, but we make a variation in areas where they will screen more or less. Or sometimes after a few months, we decide to put the malaria post at a completely different location. It has some implications because we are also, of course, directly reporting in the MIS system and collaborating with and guided by the National Malaria Program. So there we have to find an agreement. But it is a challenge, yeah. But that's how we do it, or try to do it.
Thank you. The next question is for Dr. Ross. What data would you need from country programs to go into the model? Is there data that you must have and other data that's not necessary, but would strengthen the model?
Thanks. Yeah, that's a great question. And there was another question, I think, earlier on that was very similar about whether studies would be needed on accessibility and the geospatial location of testing sites. So the accessibility network, so essentially kind of, how long it might take to get from A to B, that data is all inbuilt into the model already. Using existing data sources. Information about where the specific testing sites are, so where Vivax cases are being reported from, and then where you might be interested in considering implementing a G6PD test. That information would have to come from the country. So ministries of health will have, good databases generally of, where the facilities are based across their countries. So I think in most cases that shouldn't be sort of too difficult to include in the optimization and then model, and then you just need the GPS coordinates for those health facilities. Other data that's important to have that would have to come again from the Ministry of Health or the elimination program is on the numbers of cases. And similarly, the previous question, one of the assumptions here is that the burden will be sort of stable over time. And so we would probably want to look at where cases had been reported from in the previous, say, 3 years, and then sort of map that as a risk surface, assuming that risk is fairly stable over time. So that's an assumption. So that data would need to come from the Ministry of Health, and then other data would be things like the cost of different aspects of the implementation. But again, all of this data might be kind of a bit time consuming, I guess, to assemble, but it should be all data that is available and is routinely available. So it shouldn't be anything too difficult to get hold of. Thanks.
Thank you. One last question for our speaker, Dr. Levin. Can you describe how community dialogues are being used to increase uptake of testing and treatment, especially radical treatment, as recommended by Dr. Kamini?
Yeah.
And then
Thanks.
I think we'll close with a general question, which goes to NMCP colleagues.
Okay, thank you very much for the question. Community dialogues are in a first step, in a first phase. So through the community dialogues, we work, or they are organized in a first step, supported by the MC staff. In a second phase, the MC staff, they will train again some community volunteers to bring people together and to discuss about what is, to say very very simple, very easy. What are the disadvantages and what are the advantages of getting tested regularly? And if you have PV, what can be the possible solution, and how if you not do the radical cure, if you would not be treated, what is the risk again? So these are the, how to say, the ideas that the facilitators, the community facilitators, maybe have in their head prepared, but they leave it up to the community again to come up with solutions for this. So it's a bit a different approach, not where our team is going into the communities and telling this is radical cure and this is what you should do and explain them. No, this approach through the community with community volunteers bringing together. And again, now it's a bit difficult due to COVID to do that. But the idea is give the problem or give this, give the problem back to the community and see how they can find solutions. Most of the communities, they have resources. They know how to help each other, how to deal with this, and how to try to, let's say, persuade, convince their peers for this treatment. That's a bit what we try to do. I have to say it very shortly, but it's a bit a longer process. But I hope this is an answer to the question. Thanks.
Thank you. Here's a question for the audience, actually. So the question from Jocelyn is, why do our NMCP colleagues, what do our NMCP colleagues think about the feasibility of a multi-sectorial and malaria council forum, as described by Isaac, to facilitate progress towards elimination in our region? Do we have volunteers from our NMP colleagues to answer this question?
Or anyone from the audience, what do you think of that idea?
Can I just make a comment on that?
Yes, please. Leo, you were going to make a comment on that question about in malaria councils?
Yeah, what I wanted to say was, well, malaria generally as a whole, it's something that has to be dealt with right across the board. It is not only something that should be dealt with by, say, like programs alone. It needs a sort of a multi-sectoral approach and even community approach. It means that if we try to stick to the programs alone, we may not be able to do many things that we can, because the malaria control work is it requires a lot of other things besides just looking at malaria itself. It requires logistics, many different things. That's why I believe that having multi-sectoral partnerships and approaches probably is much more meaningful than, and we can achieve a lot more rather than just sticking to the health alone issues. I mean, that's the kind of comment I just wanted to make. In supporting, you know, some of these multi-sectoral partnerships that many countries have. Thank you. Over to you.
Thank you. I'm told we have some time, so let's end with the last question from Melanie. That's for 11. Can you share about compensation mechanisms and any challenges with sustainability?
Yes, thanks. I just answered in the chat already a bit, but I'm happy to share it all. Yes, of course, there is compensation. The mobile malaria workers, and as well the village malaria workers, which we also have under the national program in Cambodia, they get some compensation. So they get a certain amount per day. Like our mobile malaria workers, they get $5 per day that they work. And if they make some transport costs, they also will get paid some transport costs depending on the place where they live. So there is some compensation, of course, also for attending the meeting. But this is all similar or lined up and with the national malaria program. So we apply the same compensation rates. Sustainability, there are in the past, there was another organization or NGO, and they had some MMWs working in the plantations, in the big companies. And some of them are, after that project has been closed, integrated in the national malaria program, which is a very good way of sustaining that type of work. So it's a bit a double question. It's a very personal opinion. I think it is sustainable if it's integrated in a broader program. From the other hand, I can see that Malaria Consortium is doing a lot of effort in giving support and monitoring the MMWs. So they're really closely supported, followed up, very well trained by the health center staff. And this might be reduced because of financial reasons if it goes into a national malaria program or in another program. So I think it's very important to decide in what phase of your elimination or in what phase your country is to use this kind of methodology for a very specific area or a very specific objective or reason. Like now we are working along these borders, let's say the 10-kilometer area, and there is a very specific reason why we are there, because some of the health centers are so far, sometimes 50 kilometers or more. There are no roads, it's difficult. So that's another point or issue to take into account. If using this model, using this program, in what phase do you do it in your elimination or where your country is in? Just to target very specific goals. So it's a bit of double feeling I have. You can question it. Should it be sustainable if you maybe reach some of your objectives in that specific area? So you can go a bit both directions. I hope that's an answer. I think you're on mute. You're on mute, sorry.
I did press unmute, but I don't know why. But thank you for everybody for your great presentations. And I think we had really good questions here. So hopefully we can continue this discussion in the afternoon, in a few hours actually, for the group sessions. We're going to take a short 5-minute break, but during this time, I believe we're going to be uploading the pictures that you sent in yesterday and today, pictures that make you smile. So somebody from the Secretariat going to do this, Manoj?
Yeah. Do you see them on the slide now? Right. So these are the submissions
yeah.
we received. Yeah. And while you take a look at this, while you also look at the Facebook event page, I have two things to remind you. One is that I would like to reemphasize that Dr. Chansula's responses are in a file in a chat box. Please go take a look at that. And there's also a good news that just broke that we've heard from PAVE and Dr. Gonzalo that the Disk Speed Analyzer ERPD approval has been extended until July 2022, meaning that the countries will now be able to procure through the Global Fund if they want to. So that's a good news there. And while we're at it, I think we're counting how many likes we're getting on the pictures. So by the end of the day, we will decide, and it'll be a surprise gift on your way. Okay. I think whoever kept Dr. Kamini Mendes there, that's going to be a winner.
Okay, so we'll take a few minutes break from now and resume in about 4 minutes.
We'll come back in about 4 minutes. Okay, we can resume. I think we've completed our 5 minutes break, and let me introduce the chair for the next session, Dr. Hamadi. Dr. Hamadi is the Acting National Malaria and Leishmaniasis Control Program Manager at the Ministry of Public Health in Afghanistan. She's also been serving as the Head of Training and Research Department at MOPH since 2009. Dr. Hamida, are you there?
Thank you. Thank you, Sandy, for your warm introduction. Now I would like to welcome all for the next session, group work on strategies for increasing radical cure among remote population. Before to start group work, I want to present some points related to this topic. As you know, lots of studies shows that delivery of safe and effective radical cure for Plasmodium vivax is one of the greatest challenges for achieving malaria elimination. As we know, basically malaria is rural disease and mostly affecting remote population. And we know at remote area, patients only have access to primary health care with limited resources. For example, in my country, Afghanistan, majority of malaria cases are reported from community level. And considering current challenges of Afghan population, such as ongoing insecurity issues, hard to reach geographical area, low community awareness, illiteracy, and lots of other problems, patients difficultly got access to health facilities. Therefore, we establish a referral mechanism for radical cure of Vivax malaria. And this mechanism, malaria cases diagnosed by using rapid diagnostic test, and the positive cases referring from community to health facility level for radical treatment. But considering above mentioned challenges, we are still not sure whether the patients are going to the upper level of health facility and receiving radical cure or not. Like Afghanistan, other countries also using different mechanisms based on their context. So based on that, for increasing radical cure among remote population, strong strategies are needed to ensure the effective treatment and radical cure of malaria. Therefore, this session consists of an important group work that deal with accessing remote population. To tell you more about the group work, let me call on Yuching Desai. Yuching Desai is a senior case management associate at Clinton Health Access Initiative. Over to you, Dr. Yuching Desai.
Thank you very much, Dr. Hamida. Following up what Dr. Hamida has mentioned, in this session, we are going to have the group discussion on the topic of strategies for increasing access to Vivax radical cure among remote populations. The aim of this discussion is to identify and learn about current strategies to increase the access to Vivax diagnostic and treatment. As you may also hear from the earlier talks, there are some challenges around this topic. So we will have 11 facilitators during the discussion. All the facilitators, please switch on your video if you are fine to do so. You can also distinguish our facilitators by their names on the Zoom. After the facilitator name, you will see it is noted as the facilitator. Next slide, please. So during this session, we are going to have about 10 breakout rooms. You will be assigned to one group, automatically move to the breakout room later. There will be 30 minutes for this discussion, and we will have 5 questions ready for you to discuss. After 30 minutes, you will be automatically moved back to the main room, and several groups will be randomly chosen to present to all the participants. So here are the 5 questions that we would like to discuss, and all the facilitators will have these questions ready in your breakout room, so you don't need to take note for now. The 5 questions are, first, do your programs have any dedicated strategies to increase access to Vivax case management among remote, mobile, or hard-to-reach populations? Second, of the strategies being used by the group, which is most feasible sound to increase coverage of Vivax case management in your setting? Third, are there any innovative strategies or research on access that countries or partners are using or researching that you would like to learn more about? Or what can we do differently in your country or in the countries where you are working in to improve access to Vivax diagnostic and treatment care among most at-risk communities? And last but not least, are there ways that you can leverage multi-sectoral collaborations to increase the access? So now we will have number 1 to 10 groups, and you will be beamed out to your breakout room now.